1 in every 2 people over the age of 60 in this country is taking a B12 supplement right now. Their doctor told them to. The bottle says it's safe. The pharmacy said nothing, and yet, quietly and visibly at the cellular level, a significant number of those people are triggering a cascade of vascular damage that will not show up on any standard blood panel for years. This is not a scare tactic. This is not clickbait. What I am about to show you is a documented, peer-reviewed physiological conflict that sits buried in the literature, known to researchers, unknown to most prescribing physicians, and almost entirely invisible to the 70 million Americans over 60 who take one of these 2 medications every single morning without thinking twice. If you are over 60, if you take a B12 supplement, and if you take either a proton pump inhibitor or a metformin-class diabetes medication, stay with me. The next 15 minutes could be the most important thing you watch this year. I have spent 15 years in cardiology and functional medicine watching patients do everything right on paper, eat well, exercise, take their vitamins, and still deteriorate. And in case after case, when I traced it back, this interaction was sitting right in the middle of the timeline like a tripwire nobody warned them about. This is not a vitamin problem. This is a pharmaceutical nutritional interference problem, and nobody is talking about it. Lean slightly forward, measured, confident, slightly frustrated tone. Here is what the healthcare system is extraordinarily good at: writing prescriptions. Here is what it is catastrophically bad at: understanding what happens when those prescriptions interact with the over-the-counter supplements you are taking on top of them. Your standard 15-minute appointment is designed around billing codes. There is a billing code for diagnosing hypertension. There is a billing code for prescribing metformin. There is no billing code for a 40-minute conversation about how long-term metformin use actively depletes vitamin B12 from your body while simultaneously disrupting the very intrinsic factor your gut needs to absorb any replacement B12 you take orally. Nobody in a white coat is going to tell you this. Not because they don't care about you, most do, but because the system they operate inside was not built around that conversation. It was built around throughput. The pharmaceutical industry profits when you stay sick enough to keep buying medications. The supplement industry profits when you keep buying supplements. And the beautiful, tragic irony is that in this particular case, one product you are buying actively sabotages the other. And both industries collect your money while your peripheral nerves quietly degenerate. I am not here to sell you anything. I am here because I got tired of seeing 68-year-olds with numbness in their feet, cognitive fog, fatigue they can't explain, and realizing the answer was sitting right there in their medication list the whole time. Warm, direct. Look straight at camera. Brief pause before and after. Before I go any deeper into the physiology, and I am going deep because you deserve the full picture, not a dumbed-down summary, I want to ask you something. This channel exists entirely because people like you share it with people they love. We are 94,000 subscribers away from 100,000. That number matters because it determines whether YouTube promotes this content to the people who need it most. The 67-year-old scrolling at 2 a.m. because she can't sleep and doesn't know why. If this video gives you one useful thing today, hit subscribe, hit like, leave a comment. Every single one of those actions is an algorithm signal that says, push this to someone else who needs it. You become part of the distribution chain. That is not nothing. That is potentially someone's health trajectory changed. All right, let's get into the biology. And I promise you, this is where it gets genuinely fascinating. Optional, cut to whiteboard or animated diagram. Slower, teaching cadence. Let's start with what B12 actually does in the body because most people think of it as an energy vitamin and leave it at that. That framing is almost insulting to how essential this molecule actually is. Vitamin B12, cobalamin, is a coenzyme that sits at the intersection of 3 of the most critical physiological processes in your body after 60. First, myelin synthesis. Myelin is the fatty sheath that wraps around every nerve fiber in your peripheral and central nervous system. Without sufficient B12, myelin production falters. Nerve conduction slows. You feel it first as tingling in the extremities, then as balance problems, then as what doctors euphemistically call mild cognitive impairment. Second, homocysteine metabolism. B12, along with folate and B6, is the primary driver of the methylation cycle that converts homocysteine back into methionine. When B12 is depleted, homocysteine accumulates in the bloodstream. Elevated homocysteine is not benign. It is directly toxic to the endothelium, the single-cell lining of every artery in your body, triggering oxidative stress, inflammatory cascades, and the early fibrotic changes that precede arterial stiffening and cardiovascular events. This is not a theory. This is a documented physiological reality that has been replicated in hundreds of controlled studies since the 1990s. Third, mitochondrial function. B12 in its active methylcobalamin form is required for the synthesis of succinyl-CoA, a key intermediate in the Krebs cycle, the energy production loop running inside every mitochondrion in your cells. B12 deficiency at the cellular level means your mitochondria cannot complete this cycle efficiently. ATP output drops. You are not tired because you are lazy or old. You are tired because your cells are literally running out of fuel. Now, enter the two medications. Medication 1, proton pump inhibitors. PPIs, drugs like omeprazole, pantoprazole, esomeprazole, are among the most prescribed drugs in the world. They suppress gastric acid production. Here's the problem. B12 in food is bound to proteins. Gastric acid and pepsin are required to cleave B12 free from those proteins so it can bind to something called intrinsic factor, a glycoprotein secreted by parietal cells in the stomach lining. How intrinsic factor then chaperones B12 to the terminal ileum for absorption. Suppress the acid, you suppress the entire liberation step. You are eating B12, you are swallowing B12 supplements, but you are drinking through your legs. The molecular machinery to absorb it has been chemically dismantled. Medication 2, metformin. Metformin is the first-line medication for type 2 diabetes and is taken by approximately 120 million people worldwide. A 2019 study published in the British Medical Journal, tracking over 9,000 patients on long-term metformin, found that metformin use was independently associated with a 13% increased risk of B12 deficiency and a 7.7% increased risk of peripheral neuropathy compared to controls. The mechanism is dual. Metformin disrupts calcium-dependent membrane action in the ileum, directly impairing intrinsic factor-mediated B12 uptake. It also appears to alter the gut microbiome in ways that reduce endogenous B12 synthesis from intestinal bacteria. Now here is where it compounds. A 72-year-old on a PPI for reflux and metformin for diabetes is not facing one absorption problem. They are facing two simultaneous, mechanistically distinct absorption failures hitting the same nutrient at the same time, while their baseline gastric acid production is already 40% lower than it was at age 40 due to age-related parietal cell atrophy. And they are taking an oral B12 supplement that requires the very absorption machinery both drugs have compromised. This is not a B12 problem. This is a pharmaceutical absorption architecture problem, and the standard serum B12 blood test often misses it. Because serum B12 measures total cobalamin, including inactive analogs that look fine on paper while your functional bioavailable methylcobalamin is critically depleted at the tissue level. Direct, slightly emphatic. This is the correction moment. Let me stop here and address the single most dangerous myth in the B12 conversation, because it is actively harming people and I hear it constantly. The myth: my doctor checked my B12 and it was normal, so I'm fine. This is clinically false, and here is why. The standard serum B12 test measures total cobalamin in the blood. It does not distinguish between active methylcobalamin and hydroxycobalamin, the bioavailable forms your cells actually use. and inactive coronoid analogs that your body cannot utilize. Studies have shown that up to 50% of patients with normal serum B12 levels are functionally deficient when you measure downstream metabolic markers. The correct functional markers are methylmalonic acid, MMA, and homocysteine. When B12 is functionally insufficient, MMA accumulates in the urine because the methylmalonyl-CoA mutase enzyme it powers stalls. Homocysteine rises because the methionine synthase reaction it catalyzes also stalls. A normal serum B12 with elevated MMA and elevated homocysteine is not a normal B12 patient. That is a functionally B12 deficient patient with a falsely reassuring blood panel. The reference range on a standard B12 test was also set based on the average of a population that includes many deficient people. A level of 200 pg/ml is technically within range in most labs. Neurological symptoms of deficiency have been documented at levels below 400 pg/ml. You can be symptomatic and normal at the same time. So when your doctor tells you your B12 is fine, ask them, did you also run methylmalonic acid and homocysteine? Watch their face. The answer, almost always, is no. Slightly slower pace. Let each step land. Optional lower third text overlays. Here's what 15 years of clinical practice, combined with the current literature, tells me is the most rational protocol for an individual over 60 who is on a PPI, metformin, or both. This is not medical advice for your specific case. Always work with your physician. But this is the framework I use as a starting point. 1. Switch the form of B12 immediately. Stop oral cyanocobalamin tablets. This form requires full absorption machinery to work. The exact machinery that is compromised. Switch to sublingual methylcobalamin. Sublingual delivery bypasses the gastric absorption step entirely. The tablet dissolves under the tongue and is absorbed directly into the sublingual venous plexus. Dose: 1,000 micrograms, 1 mg. Sublingual methylcobalamin. Daily, hold it under the tongue for a minimum of 90 seconds before swallowing. The brand matters less than the form. Methylcobalamin, not cyanocobalamin. 2. Timing matters. Take your sublingual B12 30 minutes before breakfast on an empty stomach. Do not take it within 4 hours of your metformin dose. Some research suggests metformin's effect on ileal absorption may transiently inhibit uptake even of sublingually delivered forms by altering mucosal calcium transport. Separate them by at least 4 hours. 3. Add methylfolate, not folic acid. B12 and folate are metabolically codependent in the methylation cycle. Taking B12 without adequate folate is like running one engine of a two-engine plane. Take 400 to 800 micrograms of L-methylfolate, 5-MTHF, not standard folic acid, which requires enzymatic conversion. Many people over 60 cannot efficiently perform due to MTHFR gene variants. Take it alongside your B12 in the morning. 4. Add a calcium supplement strategically. Calcium supplementation at 1-200 mg per day has been shown in controlled trials to partially reverse metformin-induced B12 malabsorption by restoring ileal calcium-dependent membrane function. Take calcium carbonate or calcium citrate. Citrate is better absorbed in low-acid environments, with your largest meal of the day, not within 2 hours of your B12. Do not exceed 1-200 mg daily from supplements alone. 5. The morning tonic, 30 minutes before breakfast. Juice of half a lemon, approximately 15 ml, in 200 ml warm water. This sounds absurdly simple. Here is the mechanism. Lemon juice provides citric acid, which mildly acidifies the gastric environment, partially counteracting PPI suppression. It also provides a small amount of folate and potassium. It will not fully restore acid production, but it creates a slightly more favorable biochemical environment for the limited absorption machinery that remains functional. Cost: negligible. Available in every kitchen on Earth. 6. Request functional testing. Ask your doctor to add methylmalonic acid, urine or serum, and homocysteine to your next blood panel. Target, MMA below 270, MOL L, homocysteine below 10, UMOSLSSL. These two numbers will tell you whether your intervention is working far more accurately than a serum B12 recheck. 7. Consider quarterly intramuscular B12 with your physician. For individuals with severe absorption compromise, sublingual delivery may still be insufficient. Intramuscular hydroxycobalamin, 1-to-1 measure injection every 3 months, completely bypasses the gastrointestinal tract. This is the gold standard for true B12 repletion in malabsorption states. It requires a prescription and administration by a healthcare provider, but the cost is minimal and the effect is dramatic. Settle back. Warmer tone. Storytelling pace. Slower, more personal. I want to tell you about a patient I will call Margaret. She was 71 years old when she came to my clinic. Retired school teacher. Meticulous about her health. The kind of person who kept a spreadsheet of her supplements and brought it to every appointment. Margaret had been on omeprazole for 8 years for gastroesophageal reflux. She'd been on metformin for 6 years for type 2 diabetes, and she had been taking an oral cyanocobalamin supplement, 1,000 mg daily, for 4 years because a previous doctor had mentioned her B12 was a little low. When she came to me, she described 3 things: fatigue that sleep did not fix, numbness in her feet that she had started attributing to just getting older, and what she called word-finding problems, reaching for a word in conversation and feeling it just out of reach. She had mentioned all 3 symptoms to 2 different doctors. Both had run standard blood panels. Both had told her everything was normal. Her serum B12 came back at 312, pgEML on her most recent test, within the reference range. Her doctor had noted it was fine. I ordered a methylmalonic acid and homocysteine panel. Her MMA was 487 mol/L, nearly double the upper threshold. Her homocysteine was 18.4 UMOL/L, a level associated in the literature with a significantly elevated risk of cognitive decline and cardiovascular events. She was functionally B12 depleted with a normal-looking blood test. We stopped the oral cyanocobalamin. We started 1 ml/sequanoric sublingual methylcobalamin daily, separated by 4 hours from her metformin. We added L-methylfolate 400 mcg. We added calcium citrate 1,200 ml with dinner. We started her on the lemon water protocol each morning, and we arranged quarterly hydroxycobalamin injections with her GP. At 12 weeks, her MMA had dropped to 198 nmol/SL. Her homocysteine was 9.1 UMOL/L. The numbness in her feet had reduced by roughly 60% by her own rating. The fatigue was, in her words, almost gone. And she told me something that I think about often. She said, "I thought I was just getting old. I thought this was what 71 felt like. I didn't know this was something that could be fixed." She was not getting old. She was being systematically depleted by a combination of medications that nobody had warned her about, while a test that looked reassuring gave everyone permission to stop looking. Shift to direct address. Warm, curious energy. Pause after asking. Here is something I genuinely want to know because it shapes what I make next. How old are you? Drop your age in the comments right now. Just the number. That's all I need. The physiology of B12 absorption changes meaningfully at different life stages. A 52-year-old on metformin has a different risk profile than a 74-year-old on both a PPI and metformin with age-related gastric atrophy on top. A 48-year-old woman in perimenopause has different methylation demands than a 68-year-old man with early signs of peripheral neuropathy. I want to tailor future content to your actual physiology, not a generic over 60 category. Your age in the comments helps me do that. And if you are watching this and you are not yet 60, do not skip this. This interaction can begin doing subclinical damage a decade before it shows up clinically. The time to understand this is before you are in the chair describing numbness in your feet and wondering when it started. Phase 9, the conclusion. Slower. authoritative, end on a beat of genuine conviction. Let me give you the summary, T1, because if you share this video with someone, I want them to have the essential points, even if they only watch the last 2 minutes. 1-proton pump inhibitors and metformin are the two most common medications that deplete and block B12 absorption in adults over 60 through 2 separate compounding mechanisms. 2 standard serum B12 tests are unreliable for detecting functional deficiency. Methylmalonic acid and homocysteine are the markers that tell the real story. 3. Oral cyanocobalamin supplements are largely ineffective when absorption machinery is compromised. Switch to sublingual methylcobalamin, $1,000 mcg, held under the tongue for 90 seconds, 30 minutes before breakfast. 4. Separate your B12 from metformin by at least 4 hours. Add L-methylfolate, not folic acid. Add calcium citrate 1,200 ml with your largest meal. 5. The lemon water protocol, half a lemon in 200 milliliters of warm water, 30 minutes before breakfast, gently acidifies the gastric environment and creates a marginally better absorption window. Simple, cheap, effective as a supporting measure. 6. For severe compromise, quarterly intramuscular hydroxycobalamin bypasses the gut entirely. Ask your doctor. 7 symptoms of functional B12 deficiency: fatigue, tingling extremities, balance issues, word-finding difficulty, low mood, are often attributed to aging. They are frequently not aging. They are a correctable deficiency in a system that was never warned about a known drug-nutrient conflict. The system profits from your treatment. I profit from you not needing me anymore. That is the only business model I have ever been interested in. Take this information, verify it with a physician who will listen, and then take care of yourself with the precision you deserve. I will see you in the next one. The system profits from treatment. I profit from you not needing me anymore.